Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha and I am a nurse here at UWorld. So today we're going to be taking a closer look at Addison disease versus Cushing syndrome. So I like to think of these two disorders as sort of like a yin and a yang. They're going to be inversely related to one another, meaning they're like opposites. There are going to be challenge questions throughout today's video, so make sure you stay tuned for those. They're a great way to check your knowledge, make sure you're staying up to what we're talking about. And of course, we'll have our NCLEX style questions at the end of today's lecture. A couple of housekeeping things before we get started. Follow us at UWorld Nursing if you haven't already. That way you don't miss any of our future lectures or our question drills going forward. Also, let us know in the comments when you test or if you've already tested so we can either wish you good luck or congratulate you. This live will be on demand on all of our social media channels after we're done. So if you have to leave early, maybe you join late, you're always able to drop back in and use it as a future study reference whenever it suits you. As always, drop your comments, your questions, and of course your answers to today's questions in our chat feature. I see a couple of you are already chatting in there and we love to see it, but Nurse Jasmine will be moderating for us. So again, questions, comments, and answers all go in the chat. Let us know what you're thinking. Let us know what you have going on. Before we dive into these separate disease processes, let's look at the root cause. What's really going on here? What's the pathophysiology behind this? And luckily, it's pretty similar for both Addison disease as well as Cushing syndrome. Again, it's just opposite. It's that yin and the yang. So we are going to jump to our overview. So these two disease processes are resulting from disorder of the adrenal cortex, which is part of the adrenal gland. They have to do with the body's stress response, essentially. So let's break that down a little bit further and look at the body structures that are involved in the body's stress response. First, we have the pituitary gland. Now, this sits at the base of the brain. You may have all heard about it before, but this gland releases a really important steroid to today's lecture, and that's called adrenocorticotropic hormone, or ACTH, as we'll call it for short, because that is quite the mouthful. So what this ACTH does is it makes its way down to the adrenal glands, which sit on top of either kidney. So again, pituitary gland at the base of the brain, and the adrenal glands are at the base of the kidney. So it's kind of a long way for them to work down. What this does is it stimulates the release of multiple corticosteroids. And I'm going to ask you all a question, our first question in the chat: which is the most important corticosteroid that's released by the adrenal gland? All right, the most important corticosteroid that's released by the adrenal gland. I'll give you a hint. It is the basis for both Cushing syndrome and Addison's disease. In one, you have too much, and in the other, you have too little. So drop the name of that steroid I am looking for. That's going to be kind of the crux of what we're talking about today. So I'm going to give you a few seconds to go ahead and drop that in there. In the meantime, if you haven't followed us already, go ahead and do that. We just reached 80K on TikTok. We're so excited about it. And again, it is thanks to you guys following us, watching our videos, and staying up to date with what we're doing. So we're so grateful for that. And if you haven't followed yet, there is just no time like the present. All right, so I see lots of comments and almost all of you guys got it correct. Cortisol was what I was looking for. This is the most important corticosteroid released by the adrenal gland as it applies to Addison disease and Cushing syndrome. It's the basis of what we're going to be talking about today. So cortisol is a stress hormone. It plays a key role in mounting the body's stress response. So in Addison disease, this is the hypofunction of the adrenal cortex. So here we have low corticosteroids, which will include low cortisol, again, the most important thing we're talking about today, low aldosterone, low androgens, and that decreased aldosterone has to do with a lot of sodium and water retention in the body. Those low androgens is a key hormone in sexual development and growth, so that's going to cause a lot of our manifestations as well. Now on the flip side, in Cushing syndrome, we're on the too much, too high side of things. So here we have high cortisol and the hyperfunction of the adrenal cortex. It's shooting out too much of that cortisol. Alrighty, so we're going to flip to our Addison disease image. So what are our clinical features of Addison's disease? And again, this is on the too low end of the spectrum. We don't have enough cortisol. So Addison disease, the most common pathology is going to be autoimmune, which leads to the chronic destruction of the adrenal gland and not enough corticosteroids in the body. So the body essentially cannot adequately respond to stressful circumstances because we don't have enough stress hormone. This results from decreased corticosteroids. So mostly cortisol contributes to the symptoms of Addison's disease. Some of the clinical features are also related to low aldosterone and the androgens being low as well. But our clinical features for Addison disease are going to be things like a really low mood. Clients may experience depression. They may see a hyperpigmentation of the skin, which gives them kind of an overall bronzy look in most clients, which to me kind of sounds like a nice summer tan. But I think a great way to remember this is JFK, or John F. Kennedy, one of our past presidents. He had Addison disease. And if you look at pictures of him, if you Google them, he does have that bronzy pigment to the skin. But this is a well-known, well-documented side effect of Addison disease. We can have decreased pubic and axillary hair, which is due to those low androgens, which again play a key part in the body's sexual development. Hypotension, we'll see low blood pressure here with decreased cardiac output. Clients can also experience GI symptoms like a decreased appetite. They'll have a craving for salt a lot of times too. Again, this goes back to that aldosterone, which has so much to do with sodium and water regulation in the body and controlling the balance there. This is why these clients are going to be craving salt. Clients with Addison disease may also be lethargic. They may fatigue easily, and this includes weakness when it comes to the musculoskeletal system. And we can also see hypoglycemia or low blood sugar from decreased insulin resistance. So Addison disease, these are all of our clinical features that I just listed, but it can advance even further into an extreme state. Does anyone know what the extreme state of Addison disease is, or essentially the extreme exacerbation of Addison disease? Go ahead and let us know. Drop it in the chat if you know what the extreme state of Addison disease is called. All right, this would be an emergency and we would have to treat it promptly. So go ahead and drop that in the chat. Again, the extreme state or extreme exacerbation of Addison disease, what is that called? In the meantime, let us know if you have passed the NCLEX or you plan to take it soon so we can wish you good luck or congratulate you. It's always so interesting to know when everyone's testing. Does anyone have it coming up? Did anyone just take it? Let us know in the chat. But I'm going to jump back in and see that a lot of you guys got this correct. Addisonian crisis is the answer that I was looking for. So what is Addisonian crisis? Again, I described it as that extreme state, extreme exacerbation of Addison disease. Essentially, it's the extreme presence of Addison disease. The body's stress response essentially is so low that it cannot even come close to meeting the body's demand for stress hormones. This can be brought on by an especially stressful or traumatic event, maybe an illness, an infection in the body. It could be from something like a car accident or some kind of abrupt life change, or even just the client discontinuing their corticosteroid medication abruptly could also put a client into Addisonian crisis. So our manifestations here are a lot like the Addison disease manifestations, but more severe. No shock there. So we're going to have severe hypotension, some really, really low blood pressures here. To compensate for that, we'll have tachycardia or an elevated heart rate, and clients can even go into shock from this. So our interventions, we want to replace that cortisol that's missing. We're going to give an IM or intramuscular hydrocortisone shot, as well as aggressive IV fluid resuscitation to help bulk up those low blood pressures. All right, so our next part, which always is so important in nursing, is teaching. How are we going to educate these clients? They're only in the hospital for so long before they get discharged, and they need to be able to live independently. So how are we going to teach them to where they can have a successful transition back to their normal life? So make sure we're telling them that any lost adrenal tissue, we can't regain that. We can't regenerate it. Once it's gone, meaning that clients are going to need lifelong hormone replacement. Like any other medication regimen, client education is going to be paramount to medication adherence, making sure they stay on top of their medications. Clients are going to need to monitor their blood pressures closely because, again, we know they can have those really dangerously low blood pressures. They're going to need to reduce stress in their environment and their lifestyle overall. Maybe they work a really stressful job. Maybe they're in a really toxic relationship. Things like that in our lives can really contribute to our stress levels. So they're going to need to do a good cleanse, look at where the stress is in their life and see what they can cut out. Clients will need to quickly report any signs of infection because, again, illness and infection can mount the body's stress response, make the body stressed out. And if we don't have enough cortisol and stress hormone to respond to that, that's going to exacerbate our Addison disease. Alrighty, these clients should also always wear a medical alert bracelet. And this is in the case that they were to be in an emergency or some kind of accident. They cannot adequately produce stress hormone to trigger a stress response to a stressful event properly. Without that adequate stress hormone, in a situation like this, the client would risk entering into Addisonian crisis. So the medical alert bracelet, it signals to any emergency responders that the client is going to need that IM hydrocortisone shot to be able to mount a stress response and actually even respond to any of their life-saving interventions if those are needed. Again, a lot of times if a client is in an accident or an emergency, they may not be able to talk and advocate for themselves. So that's why we have them wear the medical alert bracelet. In the case they were unable to let the emergency providers know that they do have this, that's what the purpose that the bracelet would serve. Alrighty, and diet. I feel like there's always a diet teaching session when it comes to nursing intervention. Diet is so important. So we want to make sure these clients are eating a high protein and a high carbohydrate diet to ensure they're getting enough nutrients. Addison disease, remember, can cause a decreased appetite. So we want to make sure they're still getting their nutrients, they're still getting all the things that their body needs, and that nutrient-dense, high protein, high carb diet is how we're going to do that. Clients will also need to increase their fluid intake due to the decreased aldosterone that we talked about earlier, which may make them crave salt. It has a lot to do with the body's water and sodium regulation. All right, great job, you guys. We're now going to switch gears into Cushing syndrome. So remember, Addison disease, we're on the low end. We don't have enough cortisol. Cushing syndrome, we have too much. We have too much to go around, more than the body knows what to do with. So in Cushing syndrome, our patho here is that ACTH from that pituitary gland at the base of the brain will stimulate release of cortisol from the adrenal cortex in the adrenal glands that again sit all the way down on top of our kidneys. So the brain down to our kidneys. Cushing syndrome, we have high cortisol. It's the hyperfunction of the adrenal cortex, which is different from Addison, which was the hypofunction of the adrenal cortex. So our patho here, a lot of time Cushing syndrome actually results from external substances. So clients may be taking medications to supplement. A lot of different things require clients to be on steroids like a glucocorticoid or a steroid like a prednisone to help with inflammation in the body. Taking too much of these, if the prescription is too large for this client, can put a client into Cushing syndrome. It can also be an internal source, can be our patho. So if a client maybe has an adrenal gland tumor or hypertrophy of that adrenal gland, we can see Cushing syndrome. We can have high ACTH from a pituitary tumor as well, which is going to lead to high cortisol, as ACTH stimulates the adrenal cortex to release that cortisol in the first place. And we can also see high ACTH from tumors elsewhere in the body. For example, they may even pop up in the lung. So it can be an internal or an external source can be causing this Cushing syndrome. So our clinical features here in Cushing syndrome, a lot of our clients are going to experience anxiety or depression. They're going to have hypertension. So aldosterone, we talked about how it leads to sodium and fluid regulation, meaning more blood volume. In turn, it's going to increase our blood pressure. So when we have more volume in a system of the same size, it's packed in there and it increases the pressure in that system. So this is why it's going to increase our blood pressure. Because of these high blood pressures too, we can see cardiac hypertrophy, the enlargement of that heart. We can see thinning of the hair on the head. Clients can have acne. They can have hirsutism, which is inappropriate patterns of hair growth. So in a woman, they may have hair growth on their chin like a beard, which is unexpected in a female client. We're going to have abdominal striae, those like purple stretch marks, a lot of times on the abdomen. Clients will bruise easily, and we can see an increased appetite. A lot of things that result from this increased appetite include hyperglycemia or increased blood sugar levels. Clients will also see progressive obesity. So this is kind of where we get this progressive obesity leads to our hallmark Cushing syndrome manifestation. So when we think Cushing syndrome, we think that central and truncal obesity, like that midsection is a little bit heavier. We can see moon face, so a really round face by extra fat deposits going to the face, extra inflammation there too. And we can see that dorsal fat, which is, no better way to describe describe it, but it's like a hump on the top of the back. But these are kind of our hallmark signs. When I think Cushing syndrome, I think of those abdominal striae, the stretch marks, the big purple ones. I think that progressive central obesity and the moon face are like our hallmark syndrome. I think when you guys see these on NCLEX style questions, I want a little, red flag, something to go off in your head, and you guys remember that these are hallmark signs of Cushing syndrome. I feel like those are just primed to be NCLEX questions. All right, so teaching, what are we going to teach these clients? So if the Cushing syndrome was caused by an exogenous source, so if it was caused by steroids the client was on for another pathology, or maybe they were on steroids to supplement for their existing Addison disease, they can actually take too much of those and it can put them into Cushing syndrome. Essentially, we can overcorrect. So what we need to do is taper those steroids or adjust the dose. If they're being put into Cushing syndrome from this steroid dose, it's clearly too high. We want to educate clients that these body changes that we talked about related to Cushing syndrome may take months, if not years, to resolve. So that moon face, that progressive truncal central obesity, these things didn't happen overnight, meaning they're not going to go away overnight. It's going to take a while for that weight to come off with diet and exercise. So we want to make sure these clients don't expect an overnight fix. Clients will also need to closely monitor their blood pressure. They may require some antihypertensive medication management until we can get it under control. We want to assess for skin breakdown, especially with all of those stretch marks, and dietary modifications. So high protein. These clients have increased appetites. We want to give them really nutrient-dense, high protein meals to control and satiate that increased hunger. We also want to supplement calcium and vitamin D to address osteoporosis that we can see resulting from Cushing syndrome. Again, any of these visual references we put up, you're free to screenshot, take with you. I love the illustrations that we have on UWorld product, so go ahead and take these with you. It's a little freebie from today's teaching session. But now I'm going to pull up a combination image, and I think this is a great way to really compare these side by side. Whenever I'm looking at a similar disease process or maybe similar medication classes, I think a great way is to look at them side by side. That's going to help you differentiate, like, what are the differences between them, which that's how you're going to actually remember it. And it's going to also help you realize what are the similarities in between it. So when it comes to Addison disease and Cushing syndrome, the only real similarity is that it has to deal with the cortisol balance in the body, the adrenal cortex, that pituitary gland, all that good stuff in the endocrine system. But the majority of the way you're going to differentiate these two, of course, is in the differences. So remember, we talked about it being yin and yang. These are kind of inverse syndromes of one another. So in this case, Addison disease, we're going to have hypotension or low blood pressure. Compared to Cushing syndrome, we're going to see that hypertension or increased blood pressure. Again, this has a lot to do with the aldosterone balance from these, resulting from these syndromes. In Addison disease, we see a decreased appetite. Clients are really not going to be all that hungry, whereas in Cushing syndrome, they're going to have a significantly increased appetite, which contributes to some of those hallmark symptoms like the moon face and that progressive central obesity. In Addison disease, we're going to see low blood sugar or hypoglycemia compared to Cushing syndrome, where we see hyperglycemia or elevated blood sugar. And lastly, in Addison disease, we see decreased axillary and pubic hair, so less body hair essentially, whereas in Cushing syndrome, we see something called hirsutism, which is that male-like inappropriate hair growth in a woman. So we'll see growth like almost in a beard pattern on a woman, on the chin, on the jawline. So again, not enough hair growth, that decreased hair growth in the axillary and the pubic areas in Addison disease versus too much in inappropriate areas in Cushing syndrome. So again, that's a great way to kind of compare them side by side. And now we're going to go ahead and use that knowledge to answer question number 1. So here we go, our first NCLEX style question of the day. Here the nurse is caring for a client who is experiencing Addisonian crisis. So again, that extreme exacerbation, the extreme state of Addison disease. It would be a priority for the nurse to, option 1, give IM hydrocortisone, 2, begin IV fluid resuscitation, 3, check that capillary blood glucose, or 4, provide a high protein meal. Drop those answers in the chat. Let us know what you guys are thinking. This is kind of a tough one. It's a priority question. So even if these are all things that we're gonna do for this client, when we see priority, it means that one is the most important. One is gonna fix the root cause or get to the root issue, which means we're gonna need to do it first. So drop those answers in the chat. Let me see what you all are thinking. And if you haven't already, now would be a great time to share this live. If you have any other nurses or nursing students in your social network, this would be a great thing to share with them. And of course, if you haven't already, give us a follow at UWorld Nursing. We have so many great resources, and most importantly, free resources for you guys to take advantage of. We have a question of the day that goes out every single day on our social media. We have a question of the week you can sign up for at uworldnursing.com. It sends an email straight to your inbox every week with a UWorld question and a corresponding rationale. So again, I know in nursing school, a lot of times I was pinching my pennies in nursing school. I know a lot of you probably are too. This is a great way to get familiar with the UWorld product in a free sense before you purchase our product. So go ahead and make sure you're on uworldnursing.com to check all that out. Alrighty. So I see lots of answers, mostly ones, but I also see some 2s and 3s sprinkled in. So our correct option today was option number 1, that IM hydrocortisone. So why was this our answer? Again, in a priority question, we want to treat the main, most concerning issue that threatens our ABCs, airway, breathing, circulation, or we want to make sure we're doing the intervention that treats the root cause. So when we have Addison disease, when we have Addisonian crisis, as this question specifies, we have that lack of cortisol. We need that steroid in the body to mount a stress response here. This is treating the root cause of why the client is in the scenario that they are. We need to supplement with that IM hydrocortisone shot. If we don't give that, the other interventions that we do may be kind of a moot point, because if the body can't mount a stress response, they essentially can't respond to the interventions that we're doing. So again, treat the root cause, give that IM hydrocortisone. That is our priority. Option 2, 3, and 4, these clients do experience hypotension. So option 2, we definitely would want to give IV fluids. However, this is going to be secondary to treating the root cause and administering that hydrocortisone shot. Option 3, checking the capillary blood glucose. We would want to be checking the cap blood glucose. These clients have a proclivity to be hypoglycemic or have low blood sugar, but again, it's not going to be our priority over treating our root issue. Lastly, option 4, we want to provide a high protein meal. Again, something that we would do, but it's not our priority. We would have these clients on a high protein diet. However, eating is not going to be a priority over giving them that IM hydrocortisone shot. Also, clients that are in the extreme state of Addison disease, being the Addisonian crisis, a lot of times can even be unresponsive at this state. So we never want to put anything by mouth for a client that's unresponsive, because that's a choking, aspirating hazard. Alrighty, so great job on that one. Priority questions are hard, especially because all of those answers were technically correct answers we would do, but one of them is going to be most important to do first, and that is the challenge of a priority question. Alrighty, but welcome to NCLEX studying. That's how it goes. So question number 2, here the nurse is assessing a client with Cushing syndrome. So we're switching gears. Again, Addison is too low, not enough cortisol. Cushing is way too much cortisol. So which of the following findings would be consistent with Cushing syndrome? Is it 1, anxiety and low blood pressure, 2, central obesity and a decreased appetite, 3, hyperglycemia and thin limbs, or 4, acne and skin hyperpigmentation? Drop those answers in the chat. Let us know what you all are thinking. And I brushed on this a little earlier, but if you haven't already checked out uworldnursing.com, that is like our home base for everything that we're doing. It has our complete calendar of times, topics, and channels that we plan to go live on. You're going to see all the things we have planned for the next few weeks. You can highlight and set reminders for the things that you want to see more of. Maybe there's some topics on there that you really struggle with and you want to set a reminder to join that. Go ahead and do that. We have lots of free resources. We have great blog posts links on there. We have a link to our free trial. We have links to our product as a whole. So make sure you're checking out uworldnursing.com. Alrighty. So go ahead and drop those answers in the chat. And this is not a select all that applies, so we only have one correct option here today. But again, we're talking about Cushing syndrome. So what are our manifestations for Cushing syndrome? All right, I see lots of answers in the chat, and I see lots of 3s and 4s and some 2s. So we're kind of all over the board. So let's walk through this. Our correct option was option number 3. Remember, we're looking at Cushing syndrome or too much cortisol. So in option 1, we see anxiety, which is consistent with Cushing syndrome, but we see low blood pressure or hypotension. That is going to be consistent with Addison disease. We see hypertension or high blood pressure with Cushing. So because of that, we can cross off option number 1. Again, they both have to be right for that option to be right. Number 2 is central obesity. True, this does happen in our Cushing syndrome clients. We're going to have that truncal, central, progressive obesity, but decreased appetite is consistent with Addison disease, not Cushing. In Cushing's, we have that increased appetite, which also contributes to that progressive obesity. Option 3, our correct answer, we do have hyperglycemia or elevated blood sugars in Cushing syndrome, and we do see those long, thin limbs. We have central obesity and thin limbs. So these are both correct options, meaning option 3 is our correct answer. And lastly, for acne and skin hyperpigmentation, these are actually both features of Addison disease, meaning this question is double wrong. It's definitely not a correct option. We know we can cross this one out. So again, option number 3 was our correct option, that hyperglycemia and thin limbs, because this is the only option where both manifestations are consistent with Cushing syndrome. But great job, you guys. Way to go. Let's go ahead and bop to our QBank slide. This is a great way for all of our UWorld users that have already purchased the product to get more questions based on what we talked about today. Here's just one of the many, many ways you can filter our UWorld questions. And for anyone that has not purchased yet, here is a little sneak peek into our QBank. This is just one example of the so many ways you can filter our questions to target the areas exactly that you want to improve on. So that was our QBank slide. Go ahead and join us again tomorrow. We have a special 11 a.m. live where I'll be doing an RSV concept map. So I know that we're, mid-August. A lot of you guys are back from summer break. You're getting back into school, back into clinicals. I remember every nursing school semester, I feel like the first thing up to bat was doing a concept map. So I feel like this is really great timing. We're going to be focusing it on a pediatric population with RSV, but I'm so excited for that. It's again 11 a.m. Central Standard Time. We're back that evening at 7 p.m. with the wonderful Nurse Andrew with a pharmacology question drill. And then on Thursday, we're back at 11 and 3 p.m. Central with a most missed question drill, which is continuously one of our most popular ones. So thank you so much for joining. I know this can be kind of a difficult disease process, but I hope the yin and the yang help to explain it a little bit. Again, all of these lives are on demand after we're done. So if you joined late or ducked out early, no worries. You can always access it at your convenience. Give us a follow at UWorld Nursing, and I will see you all tomorrow.